I quite like the idea of talking in a pub. It's not my it's not my normal environment, but it feels good already. So I like a smell of burgers and a glass of beer. It's perfect. So it may seem a somewhat strange juxtaposition: the placebo effect, and surgery. So hopefully, some of what we've been doing in Oxford over the last few years will be of interest to you. So lots and lots of treatments that have emerged over the last 50, 100 years in particular are so clear and so obvious that you don't need to think too much about them. And this development of the identification of penicillin in London, but then the real ability to make it and prove that it worked as a drug happened in Oxford at the Dunn School on South Bucks Road in the 1940s at the outbreak of the Second World War. And it was perfectly obvious when this drug was given to patients that it made a dramatic difference. So the evaluation framework that you need to test it and make sure it's right and make sure it's safe is of a particular nature. And that's not the same for all things that we do, all treatments that we give, which require a different kind of structure. And I think, just worth bearing in mind that lots and lots of things that doctors have done for centuries really don't work at all. And so this is an example. If you, in the 19th century or the 18th century or indeed the 17th century, went to see a physician, almost certainly he would let your blood. There were all sorts of sophisticated instruments and techniques for doing this. So the idea was you let out the evil, you release the poison, but it doesn't work at all. It's not useful. In fact, it probably makes people worse because you're making them anemic. Other treatments like leaching or cupping, or was a treatment that was actually first practiced by Neolithic man, which was that when people had a mental disorder, particularly probably something like epilepsy, they would drill a hole in the skull, a technique called trepanning. And we've got from the archaeological record, going back 5,000 years, records of humans drilling holes in people's heads to try and treat them, to try and make them better. It was also called letting the stone. There's a very famous picture by Hieronymus Bosch describing this, and it actually continued to be used. In fact, the last people to use it were the French in the early part of the 19th century. They were actively practicing trepanning, and it is another treatment that doesn't work, and that we probably should have stopped doing it much sooner. Next slide, please. Next slide. Yeah. So what's emerged, particularly in the last 50 years, since the Second World War, is that kind of hierarchy of evidence for what we do in medicine. And it goes from just having a thought and just describing a case or two to producing a series and then testing in an experiment where you compare one treatment with another treatment. And ideally, that should be done with the process of randomization, where the patient doesn't know which treatment they've had, and if the observer doesn't know which treatment they've had as well, that's even better. That's called a double-blind randomized study, where you get rid of all of the variables that might be confusing or what's called confounding or biasing the study. So randomized, controlled, double-blind studies are the best kind of evidence for knowing whether or not a treatment works. And so this is what happens with these trials. You take a population of people and you decide whether or not those people are eligible, and then you ask them whether or not they'd be prepared to be in the study. They consent to being in it, having described the risks and benefits of being in the study. And then the process of randomization allocates people to either get the treatment that you're interested in or to get some sort of a control. And in lots and lots of drug studies, the control is what's called a placebo. So you give people the tablet that looks like the tablet, but it's not got the drug in it. It's got an inactive agent. And then you measure and compare the outcomes. Next one. So what is placebo? Well, placebo is something that essentially pleases the patient. It's from, the noun is placebo, and placebos, and it means to please. So a medicinal procedure prescribed for psychological benefit to the patient rather than any physiological effect. That's the dictionary definition. We'll come back to that in a moment. And it's got an opposite, which is what's called nocebo. So if you make people feel worse by giving something that is not what they want, then you can produce a detrimental effect on their psychological health, and you produce a negative influence. So it actually goes back. It's really, I gave a public talk in a church not long ago, so I thought I'd better look up some of the background to placebo. And in fact, it's first used, we've got Latin scholars in the audience, so I'll have to be very careful here, but I understand, hasten to be corrected, that it was a mistranslation of the 9th line of Psalm 116. And because they mistranslated it, it sort of got into the kind of common parlance. And this line was chanted by mourners at weddings. And if you hadn't got many friends or many chums, and you wanted to have some mourners at your wedding, then you hired some mourners. And these mourners sort of didn't know you, didn't know whether, but they got paid to be there. And they would chant this particular line of Psalm 116. And they were called placebos, because the line contained the word placebo. Placebos were also used during exorcisms in the 16th century. So there was if you wanted to know whether or not somebody was pretending to be possessed by the devil, rather than using a true holy relic, you would use a false holy relic, and that would allow you to determine whether or not they were actually possessed by the devil. And it was used a little bit more recently by Benjamin Franklin, who used the placebo control to debunk a really popular kind of cult at the time that was called mesmerism or animal magnetism. It was a bit similar to the sort of getting rid of devils inside the body. And he used these false controls to determine whether or not people were really ill or not. So that's a bit of background. So my main interest, and the interest of people I've been working with, has been in the use of placebo controls for treatments that are for subjective symptoms, and in particular treatment of pain, which is in what I do, orthopedics, quite a common reason people come and see me. They've got pain in their back, pain in their knee, pain in their shoulder, and we're trying to help that pain. And one of the issues is what is pain? And this was Descartes' view of pain, that there was some sort of stimulus in the periphery, and then there was a very straightforward, bit like a doorbell. You press the doorbell, and off goes the bell in your brain. And what we know now is that pain is a much, much more complicated sense than that, and that it's influenced by all sorts of different things. It's influenced partly by the severity of the injury or insult causing the initiation of the signal, but also by whether or not you're being distracted, what your thought processes are. So if you've got a kid who falls over and bangs their knees, one thing that everybody learns to do is to rub their leg. And why do you rub their leg? You rub the leg to send a whole bunch of other signals up to the brain to suppress the sensation of pain. So distracting people makes a difference. If you change the context that people are in when they are experiencing pain, then you will affect things. There are genetic influences, and there are actual chemical and structural changes within the brain that influence, as does indeed your mood. People who are feeling depressed, feeling low, will generally speaking be more likely to have a higher pain score than somebody who isn't depressed. So all of these influences moderate the pain experience. So for a given input from the periphery, a given burn, if you like, different people will register different amounts of pain in the way they perceive it. So this modulation can be at the periphery. It can also be in your spinal cord, and it can be up in the higher pain centers in your brain. So you've got these little thermostats, if you like, or painostats, and you can modulate the amount of pain by twiddling these dials. So you saw the classic definition of placebo, which is all about the psychology, all about expectations, all about changing, reward and reducing anxiety and producing contexts of understanding and meaning. What we know now is that there is also a true neurobiological component to placebo, and that certain placebo treatments' effects will change, for example, in the context of pain, release of endogenous painkillers. So that's your own body producing painkillers in your brain. And there is some evidence that particular kinds of placebo can change hormones and can change immune response. And this is made stronger if it's reinforced multiple times through what's called classical conditioning, so things like the Pavlov's dog. So there's a conditioning type of response, neurobiological, and there's an expectation type of response, which is more psychological. So these are the component parts of what might make up a placebo effect. So, and this is some work from the neuroimaging group in Oxford that Irene Tracy leads, and it's quite a nice example of what might happen in an experiment. So these are normal, well, I was going to say normal medical students, but I don't know if you can, can you say that? Probably can say that. Normal medical students. So this was an experiment done where they took a group of medical students and subjected them to a burn injury with chili powder on their skin. It's pretty painful. And they said during the course of this experiment, we're going to give you some painkillers. But we're not going to tell you, we're not going to necessarily tell you when, or we might tell you when. So they did this, and they said, tell us how much pain you're feeling. So this is the pain score here. So it's a pretty high pain score. It's 8 out of 10. And this is them being given the chili powder on the belly buttons, but no pain relief. And then what happens is the painkiller is given to the, it's a opioid type of painkiller is given to the medical students, and their pain scores drop. But they didn't know that they'd been given the painkiller. So this is the hidden use of a painkiller. So that's, if you like, the true physiological effect. And then what happened was they said to the medical students, now we're going to give you the painkiller. But they didn't change the dose of the painkiller. But they told them they were getting the painkiller. So this is the placebo response. So the placebo response is greater than the physiological response. But they kept getting the same dose of painkiller. And then they said, and now we're going to turn the painkiller off. But they didn't. And the pain goes back up. So that's the kind of nocebo type of response. Okay. And what was interesting in this study was that not only was what they were saying changing, but the way the brain was lighting up. We've got Carolina in the audience here as a neuroimaging expert. But this is an example of what happens in the brain when you subject somebody to pain. And you get an exact matching of what they're telling you with what's going on in the brain scanning. So you can modulate in the brain by suggestion what is happening to people's level of pain response. So you can, just by suggesting things to people with expectation, negative expectation and positive expectation, you can change the way the brain is registering pain. So what has interested me from the very start of my career is all about operations and surgery. I'm a surgeon by trade. And the staggering thing is what happens in surgery. First of all, there's huge variation in surgical care around the world. And so this is a bit of work we did looking at why it is that knee replacement, very common operation, is done 4 times as often in one part of England as it is in another part of England. And we looked into this in a bit more detail and compared variation in surgery across the United Kingdom and the United States. And what was very interesting was that although they're very different healthcare systems, one is fee-for-service, lots and lots of money piled into it in the United States. The other is a state-run salaried system. So you wouldn't think there were quite the same incentives then for surgeons to operate more. And you find exactly the same, you find a direct correlation between the amount of variation in surgery between the 2 countries. So the most variable surgery is stenting people's coronary vessels, and then back surgery, and then comes hip surgery and knee surgery and various other things. So in looking into that in a bit more detail, in terms of why is it that you get such variation in surgery across different bits of a country, and the same is true in different countries, on this journey to being normal person to getting an operation, what we found is that the most significant influence on variation is whether or not a surgeon feels it's a good or bad idea to do this particular operation. And that's all down to evidence in terms of how much information is there about whether this is a good thing or a bad thing to do for our patients. And the tragedy in many ways is that unlike with drugs, which are very highly regulated, lots and lots of surgical treatments have never been properly tested. And so less than 1% of surgical patients are in clinical studies. So most of what is being done in surgery is done on the basis of opinion rather than evidence. And this is, I don't know if any of you heard of David Sackett. He was one of the founders of evidence-based medicine. And he described 4 worries about the quality of evidence for treatments. And when you're going to see a GP next or see a surgeon, you want to bear in mind these worries because they're quite interesting and, in my view, quite profound. So one of the worries is that doctors, and we are a big part of the problem, might preferentially give treatments to patients who are going to do better with them. Because we all want things to go well, we all want things to do well, so doctors cherry pick patients with particular disorders or conditions to try and enhance the effect. The other thing is the patient. Compliant patients, patients who are good and who comply with their treatment, generally speaking, do better regardless of what you actually give them. So there is a variable here in terms of outcome which is to do with the doctors and a variable which is to do with the patients. It's quite noisy. Maybe there's that fracking. Is it happening? So the other thing is that patients who liked their treatment, if you had a great experience associated with your treatment and you really wanted it and you thought it was good, get a better outcome, regardless of what treatment they're actually given. And doctors who like the treatment, who think it's a good thing for their patients, will spuriously report better outcomes in the patients who receive that treatment. So all of these issues are really important in medicine. They're to do with what doctors do and think, and they're to do with what patients do and think. And essentially, it's all about bias. It's all about things that are not really to do with the physiological response to the treatment that might influence how we judge whether or not something works or not. And that's where placebo tests, placebo controls come in. And I understand, I always thought that big red capsules were better than blue ones, but apparently somebody told me, and in fact there was something that came out on a TV program recently that suggests blue and white capsules are better. Certainly capsules are loads better than small cheap, horrible little tablets. So if you want a really, really good treatment, then you have a big capsule. I used to work for a chest surgeon in Bristol back in the 1970s, and when we were doing lots of big chest surgery for lung cancer and tuberculosis and things, and he had a great big tablet made out of talcum powder that when the patients complained of pain after this operation, he would, "Sister, get my tablet," he would say. And so she'd go unlock this cabinet and bring this tablet out, and it would be a huge thing, size of a sort of great big thing like this. And he'd say, "Hang on a minute, sister. I think that might be a bit too strong." So he'd break it in half, and the patient would get half of it. So that the whole kind of and felt better. So there's a sort of that's what this is about. So setting up expectations, and if you have a capsule, and even better is an injection or something like that. I know I've had an injection. And next slide, please. The other thing is, if you have to pay more for your placebo, you get a better effect. So this is quite nice work in JAMA. So if you had a low-cost placebo treatment, it really wasn't very well appreciated. But if you pay a lot more for your placebo, then you get a stronger effect from it. So that sort of is interesting. And then, so why not surgery? Well, this is something we've been thinking about quite a lot recently. Why isn't surgery, in terms of expectations and the environment, not the most powerful possible placebo? And surgery has got this dramatic quality to it in many ways. See, surgery actually evolved in the Middle Ages. This is a scale model of the anatomy theatre built in Padua. And this is from the late 16th century. And this is another anatomy school. So surgery emerged in the Middle Ages from a desire to understand the anatomy of the human body, which was all done in public with people gazing down on this cadaver. You've all heard of Burke and Hare and the digging up of bodies and things. So this is where the bodies would go to be dissected by the anatomist. And what emerged from that was that the dead body was replaced with a live body, and in this same environment, the first operations were performed. And that's why even now, if you go up to the John Ratcliffe Hospital and you go and have an operation, you're not operated in an operating room, but an operating theatre. So it's got that sort of sense of drama, of performance to it. I'm going to theatre, is what you say, and perform on Odyssey. So next slide, please. So this is a Thomas Eakins picture showing a mid-19th century early use of anesthetics. So this is the surgeon expounding. This is the anaesthetist who's dripping ether onto a mask. And then the operation is being performed. And you can see the audience, all male, which is not good, is it? But that's what it was in those days. And this is a modern operating theatre showing you a sort of similar thing. So what better kind of environment, names, terminology can you imagine to drive an expectation, drive a placebo effect? So this is some work that Carolina and I did with Julian Savulescu, looking at what placebo controls might add to a blinded RCT. So what they help you do is determine whether something works. They help you determine how well it works, and they help you look at, because the patients getting the placebo surgery are the same as the patients getting the real surgery in terms of having an operation, you can look at risks as well. And it's much, much better in terms of understanding placebo effects than just leaving people and nothing happening. So this, again, is a review that Carolina led, where we looked to see whether or not placebo operations were being done in clinical trials. And there are about 53 of them being done. And in half of those surgical studies, the placebo surgery was just the same as the real surgery. So in other words, the real surgery wasn't working beyond a placebo effect. And we also found very little evidence of risk coming to patients having placebo surgery, because they'd obviously been carefully chosen. And they weren't operations with huge incisions and lots of risk associated with them, where generally speaking, you don't need to use a placebo control. So the determination was that if we were to do, and I'm building up to a trial that we've done here, as you can sense, the general feeling was that there needs to be some kind of a guess that there might be a placebo or a nocebo effect. You mustn't deceive the patients, and you've got to be certain that the question you're asking in the clinical trial is important enough to justify doing a sham operation on somebody. So what we did was we did a trial of a particular operation. The trial was called the Seesaw Trial. It was funded by a charity, Arthritis Research UK, and it was all about an operation on the shoulder. And it was an operation to treat shoulder pain, which is really common, and it's attributed to rubbing of some tendons when you lift your arm up and down from the side. So this patient here can't lift his arm up because of pain, and the idea is that you trim a spur of bone off from the shoulder blade, and that frees up the arm and it can move again. And this operation has become the commonest shoulder operation in the world. So it's increased in use by 1,000% over the last 10 years. We did 25,000 of them in this country, and there were around the world hundreds of thousands, probably close to 1 million operations being done. Lots of concern, lots of variation, not the fourfold variation that I talked about with knee replacement, but a 200-fold variation in whether or not you would get this operation depending on where you lived in England. So that's a real indicator of concern. So huge increase in its use, huge variation in its use, all kind of alarm bells that something was going on. And when we looked at the publications in the medical journals and literature, we couldn't find really strong evidence to persuade us about the operation. So we did an operation, we did a trial which compared real surgery, trimming off of the spur, with putting people to sleep and then waking them up again. And we found absolutely no difference between those two operations, the red line and the blue line. The green line was people that we just watched and we didn't do anything to. And the surgical groups were significantly, statistically better than the observation group. So both surgical groups got better, but there was no difference between the surgery and the placebo. And we said, why on earth are we doing this operation? So the implication of a trial like this is we have to have a really seriously different consultation with the patient. We need to really seriously think about who should be getting it and who shouldn't be getting it, and we should reduce the frequency of the operation. And what was useful to us at the same time as this trial going on was another trial was done in Finland. This was called the Fin Pact Study, and it found exactly the same thing. No difference between real surgery and placebo surgery. And we had a bit of a closer look at this. So I told you about these increases in the rates of surgery. So actually in Finland, the rate of surgery overall per 100,000 population was twice that in England. And in between were rates of surgery in Australia and in America. In the two countries where we raised the question, should we or shouldn't we do this operation? Should we test this operation? From the beginning of recruiting to the study, which was 2005 in Finland and 2010 in England, we seemed to change practice. So just raising the question amongst clinicians and patients across the whole country seems to have changed practice. And why is it important in terms of medical care, medical practice? Well, one thing is risk. And we reckon about 1 in 1,000 patients get a serious complication. So if we're doing 25,000 in this country, that means 25 people will have a serious infection, life-threatening infection, or a life-threatening pulmonary embolus. And is that risk worth it? And the other thing is cost. In England alone, this operation has cost, in the last 10 years, £1.1 billion. So every year, the cost, it got up to 150 million, and then we started the trial. That's about what it costs to run a district general hospital from just one operation done like this. So there's a risk issue and there's a cost issue, let alone a kind of, is this the right thing for our patients? And so as a consequence, what the government has done is put this operation on a list of ineffective treatments. So essentially it's said from the publication of the trial earlier this year, we should stop doing this. And so we wait to see. But that raises a question, well, what do we, so patients and doctors, I've had hundreds, if not thousands of emails about this trial now. And so this is the question, but why? If it makes me better, why shouldn't I have it? Why? And so that's raised the question about the issue of what's called open placebo. And there was quite an interesting study done in the States a few years ago looking at a condition called irritable bowel syndrome, where the patients were treated in a trial with a drug treatment and with a placebo treatment. And the placebo came in one of these big capsules that I've talked about. And at the end of the trial, lots of people had got better. And they were told that they'd got better, but they were receiving a placebo, and there was no difference between the real treatment and the placebo. And the patients said, well, but we felt better. And they said, well, yeah, no, that's the placebo effect for you. And they said, well, we want to still have the capsules, please. And the doctor said, well, no, you can't, because we're not allowed ethically to prescribe this thing for you. So the patients went out and got a manufacturer to make them some capsules and continued to take those tablets to this day, as far as I know. So there is an issue as to whether or not in certain circumstances it might not be appropriate. I don't think this is the case for surgery, because I think we're always going to find that the risks of surgery outweigh the advantage of what's called an open placebo. But might be for certain conditions that if people do feel better and we don't have an alternative, maybe we should be prescribing open placebo. I think the other aspect from my perspective is that I think for quite a lot of surgical treatments and probably for other treatments as well, it's not an all or nothing thing. So it's not that there's either no placebo effect or it's all placebo effect. It's that there's a partial placebo effect. And I think what we should be doing is understanding the components that drive that partial contribution to treatment effect and maximizing them. And it's a concern to me, as it is to many, that quite a lot of the things that are going on in the NHS at the moment are actually diminishing our abilities, what you might call bedside manner, seeing the same doctor every time, having a reasonable amount of time to see your doctor. All of these things help with improving expectation and probably therefore improve outcomes for patients. And that's just as likely in surgery as it is for anything else. So I think the issue of placebo and surgery, the issue of placebo and medicine is not an all or nothing thing. It's a graded thing. Understanding how it works and understanding how we can either not do treatments that are not appropriate or enhance the placebo where they are is an interesting space that we're in at the moment. So I think that's it. Thank you very much for your attention.